Hi, good morning. This is Dr. John Corboy of the University of Colorado and the Rocky Mountain MS Center at the University of Colorado. I'm also the co-director of the Rocky Mountain MS Center at the University of Colorado with Dr. Vollmer. Thank you very much for joining us today in these unusual pandemic times. I hope everyone is safe and will remain safe and have a productive spring and summer. Today, we're going to talk about a variety of interesting topics. And the topic that I would like to talk about has to do with the large collection of different types of medications we have, including those in the same families, those at different doses, those that are generic, biosimilars. What do these all mean? They're all very confusing, different terms, different concepts. So I'd like to sort of introduce the idea and show you some examples of these different variations on a theme of the many different medications that we now have available. And so here's the title of the talk, and that is Generics, Biosimilars, Dose Differences, Class Expansion, Off-Label Medications in MS. What does this all mean? Here are my disclosures, the research support consulting speaking honorarium, as well as I am the editor of Neurology Clinical Practice. And I will say that there will be some very modest discussion of off-label use today as well of medications. So this is now the modern era of treatment with approved medications in the United States of disease-modifying therapies for multiple sclerosis. I happened to finish my fellowship in 1992 when we had essentially, to treat multiple sclerosis, we had baclofen pretty much and steroids. There were some trials that were starting then, and we're actually finishing up with the interferons, and then with interferon beta 1b or beta seron in 1993 up through very recently with the most recent approval on March 26th of this year of ozanimod, Zeposia is the trade name for that. We now have well over 20 different molecules available, including generics, biosimilars, and any of a variety of other agents. So this can be quite confusing. And here are just a couple of highlights in bold, just to note a couple of very important time marks in our history with the use of the medications. Interferon beta 1b, as I mentioned, was the very first drug, beta seron. And then we had several other drugs that were similar with the exception of mitoxantrone, which was really an old chemotherapy that was repurposed. But the biggest next change occurred almost 11 years later with natalizumab Tysabri. This was an IV formulation, as was mitoxantrone, but it was notably different in that it was a highly selective molecule that was a monoclonal antibody, and that ushered in a new era of more highly effective therapies, but also the use of very targeted molecules, unlike mitoxantrone, which was a chemotherapy and had significant effects on the bone marrow and other organs. This is a very targeted molecule, and that was a very different and important change. Fingolimod, 6 years later in 2010, marked the first time that we had an oral medication. And that was a substantial move forward because a lot of people did not tolerate the injections at home, or for a variety of reasons, perhaps didn't wish to use natalizumab because of the risk of PML, the brain infection associated with that, or they couldn't tolerate it, or other reasons. So having the advantage of an oral medication you could take at home was a big move up. Alemtuzumab is marked in 2014 because that is notable for being the second monoclonal antibody, but also perhaps ushering in a phase where there perhaps was a significant increase in some of the risks that are seen in a highly effective molecule, though, and managing those risks became an even more important issue. In 2015, we had the first set of generics, the first generic for Copaxone or glutamer acetate, and that was called Glatopa, still is called Glatopa. And this represents the first generic into the marketplace. Tecfidera is noted because it was removed from the market, as was Tysabri very briefly, but Tecfidera was taken off the market permanently in 2018 due to side effects. Ocrelizumab represents, in 2017, the very first molecule in a class of molecules that we'll discuss a little bit more later, that has expanded over time and will expand presumably further in a few months. Siponimod represents the second agent very similar to fingolimod Gilenya, and siponimod is named Mayzent. That is important because that represents an expansion of a class. And we now have ozanimod as well, as you can see on the bottom, just approved several weeks ago. Similarly, Diroximel Fumarate below that represents a couple of different things. It represents another expansion of a class similar to Dimethyl Fumarate Tecfidera, which is available since 2013, but also it represents something that we might refer to as a prodrug, and I'll talk about that a little bit later as well. So a lot of different topics thrown in there together, and let's talk about a few of them. One thing to talk about is how do we classify the medicines? We can classify them many, many different ways. Oftentimes people classify them simply by how they're taken. That has nothing to do with how effective they are or side effects or anything else, but it is important because that will affect how people use the medication, how they tolerate the medication. And this can be by injection, orally, or by IV infusion. Also importantly, efficacy. How effective are these medications? How well do they work? And we can sort of broadly push them into the category of low, medium, and high. And I think you'll have a discussion perhaps today with Dr. Gross about more details of the medications. Can also talk about risk. That is long-term risk, not just short-term side effects, but long-term risks. Again, these can be categorized somewhat as low, medium, and high, with some having really no long-term risks, such as Copaxone, glutamer acetate, and some having somewhat higher risks, as I mentioned, alemtuzumab, but others as well. We can talk about classifying them by broad overall function. Do they suppress the immune system? Do they simply modulate the immune system without suppressing it? And then what we'd like to talk about in the future is whether or not we have repair molecules or remyelination molecules. Presently, these are not available, which is why they're in italics, but there's a lot of work being done on both of those topics. We can also talk about literally the mechanism of action. How does the drug actually act, and how does that affect the immune system in such a way that it would produce what we would hope for in terms of suppressing the new attacks and new problems with multiple sclerosis. We can also talk about the effect of the mechanism of action, which actually is the downstream outcome. So, for example, I'll show you in a moment how fingolimod and related molecules work, and then the effect of that is somewhat different between the different molecules. And that would get at the issue of the mixture of the mechanism of action and the effect of the mechanism of action. We can look at classes and the names. And starting on the upper left, interferon beta, all of the original interferons, beta serin, Avonex, Rebif, and then Plegridy, and glutamer acetate we call really immunomodulators. They don't suppress the immune system. There's no significant increased risk of infections or cancers. They modulate the immune system in a variety of different ways that ultimately result in less relapses, less new scan changes, less progression of disability. Mitoxantrone and cladribine are really chemotherapies. They were developed as chemotherapies to treat leukemias and breast cancers and other cancers. And they really have significant impacts on bone marrow function, as well as development and maintenance of different immune-based cells, as well as other cells. Nalizumab, going down further on the right, as I noted, Tysabri was the first monoclonal antibody in our system, and it was associated with a specific effect of attaching onto a molecule, integrin, and blocking the function of that integrin. And that was very effective for multiple sclerosis and remains so now. And that is a unique class of molecules. There's other classes that are also available to treat Crohn's disease, but that's the only one that is available to treat multiple sclerosis. Further down, fingolimod, siponimod, ozanimod, ponesimod, all the same family, so-called sphingosine 1-phosphate modulators, and I'll show you those in a second. Ponesimod is not yet approved, but will presumably be approved in the next year or two. Teriflunomide and with it leflunomide are noted below that. This is an example of a different type of molecule. Both are, one is a prodrug, and I'll talk about that a little bit later. It actually becomes the other drug, and the other drug is the effective molecule. But this inhibits an enzyme that then alters the function of lymphocytes. The two fumarates, dimethyl fumarate, Tecfidera, and Diroximel Fumarate are noted. These don't really have a known mechanism of action. They have several mechanisms. They may or may not be related, but also represent two molecules that when taken into your body become a different molecule, monomethyl fumarate, which is the active ingredient. Alemtuzumab is actually a broad monoclonal antibody that affects multiple different lymphocytes and doesn't just simply block as natalizumab does, but alemtuzumab Lemtrada actually removes or deletes cells. And this was the first molecule that actually deleted cells in such a way as opposed to just blocking the function as natalizumab does. Shortly following that then also was ocrelizumab, which was preceded by Rituximab, but Rituximab was never approved for the use of multiple sclerosis. Genentech elected to go forward with ocrelizumab, a slightly different, more humanized molecule. That is, the business end of the ocrelizumab monoclonal antibody is actually made from the, this is a protein, and it's made from the DNA of a human as opposed to a mouse. And that slight difference there might have slight impacts on, for example, development of antibodies against the drug. They work very similarly. And then in addition, noted there is Truxima. Truxima is a biosimilar of Rituximab. So ocrelizumab is approved for multiple sclerosis. Rituximab is not approved, but is used broadly with patients with multiple sclerosis and other autoimmune nervous system diseases. Truxima is a biosimilar. And then also noted there is ofatumumab. Ofatumumab will hopefully be approved by the FDA very soon, perhaps as early as the summer, and is a very similar but slightly different molecule. And you'll notice in the rituximab, there's an X. In ocrelizumab, there is a Z. And then in ofatumumab, there is an M in the middle. And what that means is that rituximab is a mixture, a chimeric molecule made up of DNA from both mice and humans. The ocrelizumab is more humanized. The business end, where the molecule actually interacts with the molecule on the outside of the white blood cell, the B lymphocyte, is coming from human DNA. Ofatumumab is a completely humanized molecule, representing that all of the protein that is made for ofatumumab comes from human DNA. None of that comes from mouse DNA. So a lot of different concepts in there, and let's look at some examples of these. So with, this is the S1P, sphingosine 1-phosphate modulator family. And the four over on the left, fingolimod, siponimod, ozanimod, and ponesimod represent those that are available. All of these molecules, in theory, could interact with one of 5 sets of receptors around the body in different organs. And because of the nature of the chemical interactions, all of them interact with receptor number 1. Let's see if I can make this work here. Hang on one second. Receptor 1, that's noted here. But notably, fingolimod can interact with receptor 3, receptor 4, and receptor 5. But the others, siponimod and ozanimod, only interact with 1 and 5, and ponesimod only interacts with number 1. What does this mean? It probably will not have a big impact in terms of how the medications work, because all of them will interact with both lymphocytes, neural cells, endothelial cells, and other cells around the body. It's felt that most likely the 2 most important cells are the lymphocytes, because blockade of interacting with this receptor blocks lymphocytes, white blood cells, from leaving the lymph nodes. That is one potential mechanism of action. But in addition, there are neural cells, astrocytes especially, upon which these drugs, which get into the nervous system, may interact directly with the astrocytes, and that can occur with any of these molecules. What you get when you don't have interactions with these other potential receptors with receptor 3 or receptor 4, for example, is that you have less potential interaction and side effects, perhaps, because you have less interaction at those sites. And then similarly for 5, recognizing that ponesimod also does not interact with receptor 5. So what these represent is very similar but slightly different molecules that have probably the same general mechanism of action, the same outcomes, but perhaps less side effects and slightly different variations on a theme in terms of their overall effects. In addition, they're slightly taken differently. They're all taken orally, but siponimod does not require, nor does ozanimod require a first dose observation, as is noted for fingolimod, Gilenya, because fingolimod has a very profound effect on the heart with a drop in heart rate and blood pressure. And with the development of the newer drugs, they have gotten around this by simply having a ramp up in the dose slowly over time as opposed to starting at the maximum dose right away. And this would mean that you don't have to use a first dose observation day, as is typically used for Gilenya. So this is an example of a drug class with many different molecules available and with slightly different impacts with the different medications. This is the first of the monoclonal antibodies that was used to treat multiple sclerosis, also available and approved to treat Crohn's disease, an autoimmune disease of the gut. And this is the basic outline of a monoclonal antibody, or any antibody, but the monoclonal antibodies that we're talking about are made in the laboratory as opposed to the antibodies that our normal immune system makes. They share a similar structure, and you can see the so-called CDRs, or complementary determining regions. Those are the regions that interact with molecules on the outside of cells, or actually interact with molecules themselves, and either block, in the case of natalizumab Tysabri, or actually may destroy and remove certain cells, as in the case of alemtuzumab, rituximab, ocrelizumab, and ofatumumab. And so this particular monoclonal antibody is directed against the alpha-4 integrin. That is, it binds to that, and as I'll show you on the next slide, in this case, you can see the alpha-4 integrin on the left, which is sitting on the bottom of the leukocyte there. The leukocyte is a white blood cell. And the natalizumab, the Tysabri, interacts with that, blocks that function. And as opposed to that white blood cell being allowed to then go through into the tissue, into the brain or the spine or the gut in the case of Crohn's disease, which it would normally do and then set up shop and cause the problems that we think of as MS, it's blocked and it's not allowed entry into the nervous system. In the case of the other monoclonal antibodies, they not only bind to the different molecules, in the case of the rituximab, ocrelizumab, and ofatumumab, the so-called CD20 molecule on the outside of the white blood cell, or the CD52 molecule for alemtuzumab, Lemtrada, they also then delete that molecule. Those cells are destroyed and removed. That is not the case with natalizumab. And that's a very important distinction, because natalizumab, those molecules of natalizumab will simply fall off over time, and then those cells would still be available. And that's why we have to continue to retreat with the natalizumab Tysabri more frequently. And it also is related to the fact that when we stop using the medication, is potentially a risk that you would see return of disease activity, maybe even a rebound of disease activity that is relatively unique to natalizumab, and then also perhaps Gilenya, fingolimod, and the other family members related to fingolimod. In that case, presumably it's because the lymphocytes that have been blocked inside the lymph node now can be released suddenly. So the subtle differences between the different monoclonal antibodies may lead to different outcomes with regard to impacts when you stop using the medication. When I was in training, the theory was that the T lymphocyte, one class of white blood cells, was the most important in terms of the disease process with multiple sclerosis, and many therapies were potentially directed at T lymphocytes. But there are other classes of lymphocytes, white blood cells, including the B lymphocytes, and they're pictured here. And the B lymphocytes, as it turns out, perhaps have a much larger role in causing multiple sclerosis and all the related problems. And you can see that, like every other stem cell in the body, if you follow from on the left, from the stem cell all the way up through plasma cells, the long-lived plasma cells, you can see that there's a development of these cells over time. And they will express on their surface these different time frames of the B cell development. Will have different markers on their surface, proteins that stick out of the surface of the cell. And these will be available on the outside of the cell at different times in the development of these B cells as they become so-called plasma cells, which actually make the normal antibodies that our body uses all the time to fight off infection. And this gives an opportunity for us, from a laboratory point of view, to develop molecules that will actually interact with these surface molecules, the CD19, CD20, CD52, VLA4, BAFF-R, and CD138. And these molecules are now targets where you could develop a monoclonal antibody that will attach to either the CD19, 20, etc., and then presumably be able to remove that particular class of cells. And you can see that there's a molecule that's being studied now for neuromyelitis optica and showed quite a good benefit for that. This anti-CD19 from MedImmune is noted. The CD20 molecules are Rituximab, Ocrelizumab, Ofatumumab, and there's a fourth, Rituximab, that's also being studied in MS, etc. And alemtuzumab is the anti-CD52. CD52s are also noted on these outside of these white blood cells, the B lymphocytes. So these markers on the outside of the white blood cells become targets, and you can see that they will delete. If you delete those that are expressed at different time frames, you'll delete different cells within the pattern of the development of these cells over time. Ultimately, the long-lived plasma cells make antibodies, but the earlier cells, the immature B cells, the mature activated B cells, the memory B cells, they may do a variety of other things different from development of antibodies, having to do with the regulation of the immune system, even long before the immune cells, the plasma cells, make the antibodies. So this is suggesting there are multiple different targets, multiple different ways you might remove the cells that would have a potential positive impact on treating MS. So switching gears, we now have in our armamentarium a number of different drugs that are no longer made just by one company, but are made by multiple companies and are generics, that is, knockoffs, if you will. And these are copies that one company makes of a brand name drug. So the first of these was Copaxone, glatiramer acetate is the generic name. And they're developed by a different company after the patent has expired. There's patent protection, which is allowed in many countries in the world, and protect the investment of the pharmaceutical companies that have made whatever drug that is. In this case, we're talking about Copaxone first. They have the same active ingredients, in this case, glatiramer acetate, and work the same way with the same risks and benefits. They're equivalent in dosage, safety, strength, route of administration, quality, and performance characteristics, and are required by the FDA to prove chemical equivalence. The inactive ingredients, for example, if it's in a pill, there are always some inactive ingredients, that binders and other things that hold a pill together, and those have to be acceptable, although not necessarily identical. They have the same label as the brand name medication. That is, if there's an approval for relapsing remitting MS, you get the exact same approval for relapsing remitting MS. The drug also has to be made consistently. The company has to prove that they have the factory capacity to make it consistently. But the FDA does not require that there are trials, clinical trials, to prove effectiveness. It is assumed that if they are chemically equivalent, then they would be effectively equivalent as well. The important other aspect of this is financial, generally 40 to 50% of cost savings versus a brand name. And this is broadly across many different categories of different drugs. It may be different for one drug compared to another. And in our field, unfortunately, the savings have not been anywhere near that high. So there are now 2 generic drugs, one made by Sandoz, which is a subsidiary of Novartis, and one made by Mylan. The Mylan product is simply called glutaminyl acetate, and the Sandoz product is called Glatopa. And so they're the 2 examples, Glatopa and glutaminyl acetate, and they have increasing use in MS, and the insurance companies, because they are a little bit cheaper, oftentimes prefer to use these. If you feel that you really need to or wish to continue to use Copaxone, you can, of course, ask your physician to, when they write the prescription, to write into, when they sign it, to mark dispense as written, because that suggests that you would really want them to continue to use that drug. That may or may not be available with the insurance company over time. Some are pushing more generics, and that will be an issue going forward. Now with fingolimod, Gilenya is the original trade name for that, made by Novartis. But now, last December, on the same day, the FDA approved 3 different generics from Sun Pharmaceutical, HEC Pharm, and Biocon to be also used as fingolimod agents. They haven't really made it much into the market. I think they came later in the year. The insurance companies didn't have an opportunity to react to that before they made their formularies for the January change when people turn over their insurance. This may occur coming in July. It may occur coming in next January in 2021. But again, this is a pill now, not a shot like Copaxone, and it is chemically equivalent to fingolimod. So it'll be interesting to see for this family, we not only have now 3 different drugs, fingolimod, siponimod, and ozanimod, but we also have 3 generics for fingolimod, so 6 different molecules all in the same class. And how this goes forward in terms of how people functionally use these medications will be very interesting to see. It should be noted as well that with siponimod, and subsequently to all other drugs that have been approved for MS since then, the FDA has approved all of the medications for relapsing forms of MS, to include the first attack of MS, or clinically isolated syndrome, run-of-the-mill routine relapsing remitting MS, as well as secondary progressive MS with activity, meaning that the expectation is if you have slow worsening, so-called progressive MS, that you've at least at some point in the recent past, within the last year or 2, had a new scan change or a relapse superimposed on top of that slow progression. And all subsequent molecules that would be approved for relapsing MS will include all 3 of those categories, whereas the older molecules really just said relapsing remitting multiple sclerosis, and unless there was a specific indication for clinically isolated syndrome, did not include that at all. And until siponimod came on the market, that was the first that was approved for so-called secondary progressive MS. So now also the way the medicines are approved by the FDA has slightly expanded with siponimod last year in 2019. So what's a biosimilar? Is that just another name for a generic? No, it's really not. Biosimilars are slightly different. They are not identical chemically to a different molecule, but they are highly similar is the term that is used. They are modeled after a biological drug. Well, what's a biological drug? It's not a chemical. Aspirin is a chemical. It's acetyl salicylic acid. Fingolimod is just a molecule. But biological drugs are actually different. They use living organisms, yeast, bacteria, animal or plant cells, as important ingredients. So for example, if you want to make a monoclonal antibody, you actually put together the molecule that looks like an antibody that your normal immune system makes. And you also then make that inside of living cells, either bacteria or more commonly you would make it inside of a mammalian cell. Similarly, you make the interferons inside either a so-called prokaryotic cell like a yeast, a prokaryotic cell like a bacteria, and beta-serine is made in bacteria, but all of the other interferons and copaxone are actually made inside of, mammalian cells. And then in order to get the molecule out of the cell, you crack the cell open, you get rid of all the debris, and then you have the chemical that you're looking for, the molecule you're looking for. When you want to make a large complex molecule, as opposed to just a chemical, this is the way you essentially grow or make the molecule that you want. In this case, approval requires that it not only be highly similar, but it contains no meaningful clinical differences. And this then does require that there's more clinical testing that is done. In our world, Truxima is a biosimilar of Rituximab. And in fact, patients who have been treated at Kaiser may know and may be using Truxima because they have been using that. The price savings here is not generally as high as it is with the use of generics because it's a little bit more complicated and there's more testing involved. But there's still price savings generally compared to the brand name. And in this case, the brand name is Rituximab and Truxima is the biosimilar. In addition, around the world, biosimilars are used quite frequently, sometimes with and sometimes without the patent having been expired. In the United States, that would be more problematic because of the patent and the protection of the patent. So do we have examples of biologics in our world? Sure, all of the interferons, the monoclonal antibodies as noted, and then Truxima is a biosimilar, as I just mentioned a moment ago. And so we do see a variety of biologicals that are used in our world, and we'll presumably see more of these going forward as opposed to simple chemicals that we might see, like Tecfidera or Vumerity. Those are both just chemicals as well. What about prodrugs? Well, a drug is simply a substance that is used to treat an illness, relieve a symptom, or modify a chemical process in the body for a specific purpose. A prodrug is a drug that is administered in an inactive form, or maybe a partially active form, that is metabolized in the body into a biologically active compound. So you may take a chemical into your body that is then metabolized by your body in your stomach, in your gut, other parts of your body, your liver, and then it becomes the active ingredient. And we know, for example, in our world, that dimethyl fumarate, Tecfidera, Diroximel Fumarate Vumerity, both of those get metabolized into monomethyl fumarate, and that is the most active ingredient in treating multiple sclerosis, and similar molecule called Fumiderm, which is used primarily in Germany to treat psoriasis. It's not exactly the same, but it's another variation of the fumaric acids, the fumarates. The advantage potentially for Vumerity is that Vumerity was directly compared head-to-head with Tecfidera, and although it has the same monomethyl fumarate, that's the active ingredient, it had less GI tract side effects, reduced by anywhere from 30 to 50% or so. And that's because the starting molecule, dimethyl fumarate or diroximel fumarate, was actually slightly different. So there are less GI tract side effects, and that's exactly why it was developed, to avoid some of those side effects. In addition, leflunomide, or Arava, is used in rheumatoid arthritis all the time. It's a commonly used drug. It gets metabolized into teriflunomide, Aubagio. Aubagio is a medicine that's approved for a variety of things, but most recently was approved for multiple sclerosis several years ago and is used significantly around the world. And so leflunomide can be thought of as a prodrug for teriflunomide. And in theory, you would have the same impact, although maybe the drug dosages and whatnot would be different. And Arava has never been studied in multiple sclerosis to my knowledge, but likely you could use Arava, which is much cheaper than Aubagio is. It'd be interesting to see going forward if there's more focus on trying to reduce costs, if someone perhaps does a study of Arava with multiple sclerosis patients. But I've not seen that. I've not heard of one being planned at any time, maybe in the future. So the potential advantages of the newer disease-modifying therapies that we are talking about, so ofatumumab is a potential, maybe to be approved shortly, drug in the anti-CD20 class, similar to Rituximab and ocrelizumab. It is taken as a subcutaneous injection at home. That is, there's no infusion reactions. If there's no infusion, there might be a slight reaction with the actual injection. It may have slightly different effects on lymph nodes and might have different side effects or even outcomes over time. But the biggest difference will be that it'll be taken differently and will not require an infusion having to go anywhere. Diroximel fumarate, as I mentioned, has less GI tract side effects than dimethyl fumarate, Tecfidera. Fingolimod and glatiramer acetate generics are potentially cheaper than their proprietary namesakes. And leflunomide, as a prodrug, could also be potentially cheaper than Aubagio. So these are potential advantages of either new disease-modifying therapies or those that might be used separately off-label, such as Areva, that might have similar outcomes but have different advantages. So the main points I hopefully stress today, that we are blessed with many, many different disease-modifying therapy options. And in the 27 years since beta-serin was approved, we now have over 20 different options, including biosimilars, generics, different doses, and different variations within the same class of medications. We still, of course, require balancing of efficacy, the effectiveness, and the risk of the medication versus the risk of the disease process itself in every individual, and taking into account patient preferences. All of those things will allow us to come up with the best approach for choosing a disease-modifying therapy that's individualized for that one person. Of all the new drugs, most are variations in classes or generics, which might offer some advantages over other older disease-modifying therapies. But there are other classes of medications also being studied right now, including the so-called BTK class and others that might have different impacts, as well as different molecules that are looking at regeneration, remyelination, and other things that are completely separate and have nothing to do with altering the immune system at all. And then finally, costs remain a serious problem. The whole reason that generics are coming into our market is because the costs are very high, and it's viewed as potentially a market where a generic drug maker can actually make money. How will these more generics, biosimilars, change the utilization of medications in our world? Not really clear yet, and I think it'll evolve over the course of the next several years. So thank you very much for your attention. Please, everyone, stay safe. We hope that you have a very profitable and welcoming spring and summer, and we hope to see you in the fall for our next Ed Summit as well. Thank you very much, and have a great week. Bye-bye.